Okay, Assalamualaikum warahmatullahi wabarakatuh and good morning to all the participants. Okay, welcome to the monthly neuroemergency CME class webinar. Okay, the theme of our webinar today is related to the use of ultrasound or point of care ultrasound in neuroemergency. It is a great honor to have two experts in the ultrasound world of emergency medicine. Our first speaker is Dr. Adi Osman, and then our second speaker is Prof. Madya, Dr. Muhammad Hashari Fauzi. Before I introduce the speaker, I would like to briefly explain about the running of the webinar today. Each of the speaker will roughly present their lecture for about 1 hour. After Dr. Adi's talk, we will immediately have our first Q&A session related to Dr. Sadi's talk. Okay, if you have any questions, you can either write it down in the chat area, or later on you can unmute yourself, raise your hands, and ask the questions. Okay. Throughout the talk, can I please get cooperation from all the participants to mute yourself so that you're not going to interrupt the speaker's lectures. Okay, without further ado, I would like to introduce our first speaker. Okay, for me, he is known as the guru of emergency critical care medicine, and also the guru in the use of ultrasound in emergency medicine and critical care medicine. He is currently the senior consultant emergency physician in Hospital Ipoh, and also Perak Emergency Medicine and Trauma Service State Director. Apart from being an excellent clinician and also an educator, Dr. Adi also is keen researcher in a critical care medicine, having published multiple papers in international emergency medicine journals. Okay, there are a long list of credentials about Dr. Adi Osman. Okay, his talk today will be about transcranial ultrasound Doppler in neuroemergency setting. Okay, I think he will cover about the use of transcranial Doppler in few clinical situations. For example, in the assessment of intracranial pressure, assessment of midline shift, vasospasms in subarachnoid hemorrhage, and also the use of transcranial ultrasound Doppler in management of ischemic stroke. Okay, without further ado, I would like to invite Dr. Adi Osman to give his first talk.
Right, can you hear me? Right, so Assalamualaikum and very good morning. Selamat Hari Raya dan selamat happy weekend. So my name is Adi Osman. I will ask to talk on this topic, the transcranial Doppler in neuro emergency setting. And first and foremost, I would like to thank Nina and the Neuro SIG group of the CEP for inviting me for this discussion this morning. Right. When I first received a WhatsApp message from Nasrina for me asking me to discuss about this transcranial Doppler, my first reaction at that point in time is wow, just wow. Okay. Neuroemergency, neurology is probably never been my favorite topic. In fact, if you ask all the emergency physician or critical care physician or those actually in acute setting, neuro is the most scary kind of topics, right? And because of the difficulty in terms of getting diagnosis, doing assessment, conclude based on our history and assessment, I think neurology is quite difficult. Okay, so when I asked to talk about transcranial Doppler, transcranial Doppler is neuro equivalent of equivalent to neuro for emergency physician in a focus world, right? So I'm not saying it's not cannot be done, but there's a way to do it, and people find that this is a bit difficult to get images. And once you get images, it's not easy to interpret the images, and it's not easy to get what I call it a Doppler wave, Doppler sampling. Okay, once you get these images, all right. So my task today morning is actually to make this talk less scary for you all. I know some of you have been doing this transcranial Doppler. I saw some neurologists that right? But for emergency physician, for critical care, for emergency critical care physician, this is not something that we do almost every day, right? So trust me, okay, just bear with me. It's going to be a half an hour talk, and I'm trying to make it as simple as possible so that I can convince you this is probably the way forward in terms of managing neuro emergencies.
Dr. Adi, unmute. Okay.
Right. So this is my possible potential conflict of interest. And I would like to thank Dr. Chong Chien. I think he's the one to contribute some of my slides for this lecture. And he's now in KPJ Ipoh, right? So I'd like to thank Chong for sharing some of his slides for discussion this morning, right? My first disclaimer, my talk today will not replace a formal comprehensive TCD study. My talk today is only discussing on how we use focus, especially on the usage of TCD in managing some of the condition that we're going to discuss later in my presentation, right? So it's not a formal comprehensive TCD study, right? The second disclaimer, I'm not going to talk about a submandibular transorbital or occipital approach. I'm only going to talk about things that we normally do in ED, in ICU, in acute setting, which is the transtemporal approach. And this might first, I think the most important message is, even though we can do ultrasound, okay, ultrasound will never going to replace our complete history and neurological examination. It is so much so in neurological emergency, whereby history and clinical examination play, I think, almost 99% in terms of importance of this clinical history and neuro examination in order to get the diagnosis and, of course, the plan management. In summary, okay, I put summary at the first because I think it's very important. The why we do transcranial Doppler focus, because we know this is very non-invasive, it's quick and easily repeatable, okay, at the bedside, for example, and can perform at the bedside. So what I'm going to talk this morning, basically this is how to get the MCA, middle cerebral artery, using the temporal bone. And this is where our focus of interest, and this is where I'm going to put our probe. Temporal bone, because this is a thin we choose temporal bone. If you look back into the this is where the middle cerebral artery, MCA, and from this we got to get this. This is the sono anatomy of this circle of Willis, and it representative. The presentation of this is actually clearly, if you look back into the sono, the neuroanatomy, and based on this MCA, we need to interrogate this MCA, and what we get is this. This is what we call a Doppler. Okay? So having able to get these images and get the measurement. So the next question you're going to ask me, what I'm going to do with this measurement, right? So difficult knowledge. Most of the time, people difficult to do it. People scared to do it. At the end, it becomes just a knowledge, a difficult knowledge that nobody actually doing it. So transcranial Doppler is not that difficult if you know the basic of the sono anatomy. And once you get this, there's a few ways to use it. I'm referring to this article which published in AGEM. The other article is published in a critical ultrasound journal. How to use it? We can use it to evaluation of the midline shift in ICP monitoring, In those presented to us with the subarachnoid hemorrhage, we want to look for possibility of a vasospasm. In cerebral circulatory arrest, and those in acute ischemic stroke. I'm going to go one by one on this application of this transcranial Doppler. Recently, intensive care medicine come out with this recommendation and consensus, whereby they actually put a transcranial Doppler as one of the basic ultrasound that everybody should learn. Those who actually in critical care, those who actually in acute setting should know about it. Okay? So they recommend this demo transcranial Doppler, okay? Looking at the middle cerebral artery as a basic skill. But on the other hand, it's quite weird for me that they're unable to provide a recommendation to use of optic nerve sheath diameter as a basic skill. For those, I think, for those who've been doing focus ultrasound for quite some time, we think you might be agree with me that optic nerve sheath diameter is way easy as compared to transcranial Doppler. I'm not sure why this group didn't recommend this optic nerve sheath diameter measurement as part of this basic skill. Okay. When we talk about this neuro monitoring, there's a few things that we need to consider. For example, looking at the brainstem reflexes, okay, looking at the brain function, we have this EEG, and ultrasound, the transcranial Doppler, is actually looking at the cerebral hemodynamic, whereby we can look at the cerebral blood flow, the ICP, and of course, the cerebral perfusion pressure. So, and why we do this brain ultrasound, it consists of, because eye is actually a mirror of the brain. In fact, people always say the nearest way to the human heart is through stomach. But on the other hand, the nearest way to the human brain is actually through the eyes. And before we dive deep into this topic, for those new in ultrasound, we need to actually understand the basic physics of ultrasound and how ultrasound works. We have a transducer here. Inside the transducer, there is a crystal. Okay, once electric energy passes through the crystal, it a form of, I call it ultrasound wave, right? And this ultrasound wave, we go through the medium, and once you get the object, some of them be heated back to the transducer. This is what we call reflected wave. Right, this is very important for transcranial Doppler. The second thing, we're going to use a low frequency transducer. We most of the time we use 2 to 3 megahertz. Right. The reason why we use a low frequency transducer, because when we look back into ultrasound physics, the low frequency transducer have a longer in terms of penetration. Right. But on the other hand, if you have a low interval frequency, you're going to jeopardize when we talk about the resolution, in terms of resolution. Right? So don't worry so much about this slide, kind of very wordy kind of slide. But what I'm trying to illustrate here is a Doppler effect. Right? Now remember the slide that I shown earlier. This is where I'm going to put the transducer. Our aim is to interrogate this middle cerebral artery, MCA, right? And what this Doppler does is actually it measures the frequency shift of this RBC. I repeat, the RBC, okay, from one point to the other end. Okay, so the other thing that why we choose middle cerebral artery is when we look back into this equation, the cosine something, okay, angle of insonation. So this is the brain, this is the middle cerebral artery, this is where I'm going to put your probe, okay? Okay, I purposely magnify it, and this is where I'm going to put your probe. So if we look into this middle cerebral artery, the one that I actually watermarked it, highlighted, this is where the flow of RBCs, right? And this is the flow, the ultrasound beam. So what I'm trying to illustrate here is the flow and the ultrasound. When we talk about angle of insonation is 0. So we know that if the cosine 0 is 1, okay, if the cosine 90 is 0, that's the reason why this is another limitation and another pitfall in doing TCD is angle of insonation. So in TCD, we accept anything less than 30% angle of insonation is actually insignificant, right? So anything beyond 30 degrees, 30 degree, you got to get a lower in terms of the Doppler images that come back to the transducer. Right, just to illustrate my point just now, okay, this is the flow. This is actually the ultrasound beam. Over here, you see A, B, C, and if going away from the beam, you can get a negative reflection at the baseline. So I hope I didn't confuse you all with that physics. Physics ultrasound is always something that people try to avoid. But doing Doppler TCD, you cannot avoid. Okay. The second important physics that you need to know, we're going to use two types of Doppler. One is a color Doppler. One is actually the spectral Doppler, right? Okay. What color Doppler does? What is the information you can get for color Doppler is two things. Number one, based on the color, okay, based on the color, what you can get is number one is actually the velocity of the blood flow. Number two is the direction of blood flow. Okay, can you see that there's a red, there's a blue. Looking at this, what I call it, the marker here, you can see if the flow is almost 13 maximum, it will be colored yellow, right? This is somewhere probably 5 to 6 will be red. Okay, if we're going away from the ultrasound beam or the transducer, the beam, okay, the transducer, it will color blue and light blue if the flow, the velocity is higher, right? So information they can get this color flow for transcranial Doppler is to get where is the MCA. Okay, once you get MCA, then you need to put a sampling inside the MCA. So you're going to get this, what I call it, you're going to yell this representative of this velocity with time, right? Over the time period. So you get this spectral Doppler. I hope I didn't scare you at this point of time. So what I try to say, in simple term, layman term, you have to do the color Doppler to get where there's MCA. Once you get the MCA, you need to put sample inside the MCA. Then you know how much is the velocity, etc., right? Right. And the other thing that you must understand, Doppler is not like what I call it angiogram, whereby they measure pressure. Ultrasound measure velocity, and the velocity will be converted into pressure. Okay, so ultrasound cannot measure pressure; it measures the velocity. So what we get in TCD basically is just a velocity and the direction, right? So it depends on what ultrasound they bought, right? Most ultrasound they have their own what I call it mode. They call it a TCD mode. In some ultrasound, they call it TCI, which is almost the same. TCI stands for transcranial imaging, right? And I mentioned just now, once you get the MCA, you need to sample it, okay? How much you need is sample volume. Normally use something more than 5 mm sample volume, right? Right, how to do it? Remember my first few slides just now? This is the probe. This is where we're going to position patient. Then this is where we're going to put our transducer. And if we look back into the skull anatomy, this is where the temporal bone, you can see the light at the behind of the skull bone is signified. This is the thinnest part of the what I call it skull. And this is where I'm going to put the transcranial Doppler. And if you do a cross-sectional of your head or your brain, it will look like this, of skull, right? So this is the anterior fossa, this is the posterior fossa, this is temporal fossa, okay? temporal, okay? And this is where I'm going to put your transducer. And if you look back into this brain anatomy, this is where the circles of Willis, sorry. And if you look back into the circle of Willis, if you still remember, there is a MCA, this is anterior cerebral artery, this is anterior communicating, this is posterior circulation, right? This is basilar there, right? And this is what you're supposed to get when you put your probe here. But sad to say, this is the best picture that I can get. But most of the time, in real world, you might see just a MCA. Okay, you won't get this the whole ACA, PCA, and the contralateral MCA and PCA. This is in pediatrics. Pediatrics is quite easy to get this, right? In adult, a bit difficult, right? So based on this MCA, you're going to sample this MCA. You're going to put a sampling. Can you see that sampling there? And the sampling must be more than 5 mm. It's very important to actually to get a good sampling, to get a good Doppler what you call it, image, right? And this we yell this what we call it Doppler. This is a spectral Doppler. Once you put a sample there, you press on PW, you're going to get this, right? Right, going back, in most of the time in ED, in ICU, in acute care setting, we put the head in epi position. Okay, it's very important that the probe marker should towards the anterior to eye, towards the eye. Okay, towards anterior. Right. How to do it? There's a 4 step to do TCD scanning. Number 1, you need to see once you put your probe on the temporal bone, the first thing that you need to identify is the contralateral temporal bone. This is the contralateral temporal bone, right? If you move your what call it probe slightly towards the cranium or towards the eye and move it somewhere that area, you're going to get this midbrain. Some people call it a cerebral peduncle. It looks like a butterfly. Okay, it looks like butterfly. Some people you can, okay, you can see the butterfly that is somewhere there. Okay, you're going to see the circle of Willis somewhere there, right? And if you look carefully, there is a hypoequic structure within 2 hyperequic lines. Can you see that? Okay, so this is the third ventricle. Some people use cerebral peduncle to get the MCA. Some people use this third ventricle to get the MCA, right? So once you get this butterfly or this third ventricle, you're going to put your color Doppler somewhere around this area. Okay, remember this eye is somewhere here. You're going to put the color Doppler somewhere here. And the first thing you can see is the MCA. We blink. Okay, you can see the color Doppler of this MCA somewhere here. Once you get this, then you need to reduce your depth and start putting the sample, get the sample in the MCA, right? Right. So just to illustrate my point just now, a lot of people asking me, how can I remember this, right? It's something like remembering ECG. Remember when you used to learn the ECG at that one point, those days in early phase of a medical career. Okay, we always remember the P, Q, and RS, right? And for those have interest in neuro emergency or neurology, is something like EEG, whereby you actually memorize what is normal and anything beyond normal is abnormal. Similar to TCD. This is the ECG or EEG equivalent, okay? The waveform of normal TCD. You just need to remember this. First is systolic, then this is a diastolic, right? So if you look back into this picture, there will be a sharp upstroke. This is systole, and once, okay, if it going through the phase of systole, this is the diastole, whereby the stepwise deceleration. This is a diastole. Okay. The next question people always ask me, why the diastole doesn't go back into 0? It's something like a blood pressure. We never have blood pressure 120 over 0. It's always 120 over 80, 120 over 70. Okay, so the diastolic, okay, if the diastolic is 0, you will never push the blood out from your aorta into your brain, similar back into your coronary perfusion, coronary artery, right? So it can never be 0. So you can see systolic, there's a peak there, and you have diastolic, it never reaches 0. Once it reaches 0, there's something wrong. Right? So normal velocity of this is normally around 80, less than 80 centimeter per second. Right? So if you want to start doing TCD, the first step after you're able to get the images and to get this Doppler sampling is to memorize this is a normal TCD waveform. Right? This is the MCA. Okay. So the other thing is these two things: the pulse, PI index, and the RI index. This sound very foreign for most of us. But basically, what this index measure is the resistance. If the increase in resistance, yeah, your systolic mean systolic velocity will high, right? And in the only certain condition that cause increase in resistance. For example, you have vasospasm. It's kind of self-explanatory. That is actually when you have spasm, the resistance will be high. Then you have a higher in terms of PI index, and of course the RI index will be high. You can remember this number, but as for me, I'll just remember one. Anything beyond one, I consider is slightly abnormal, right? Right. The first usage of this transcranial Doppler, especially in emergency setting, in a resource-limited area whereby you don't have a CT scan, right? In district hospital, for example, in disaster, in remote area, okay, you can actually look at the midline shift. Right? Remember that I told you just now. This is the contralateral cranial, okay, the cortex, right? This is the third ventricle. There's two things there. The hyperequic line you measure here and compare to measure the contralateral side of this cerebral. So just to illustrate, this is the patient that presented with this abnormality. It shows the midline shift. This is how they measure. This is this area. This is the distance A is 7.4. This area is somewhere around 7.6, and of course, it correlates well with the follow-up CT scan post-TCD that reveal a midline shift to be somewhere around 7 mm. So basically, you measure the hyperequic line based on the third ventricle. Right. The second usage of this TCD is to estimate the ICP. Remember that I told just now. In normal condition, you should get the upstroke, and the diastolic wave will never goes back to normal, right? But what happened when you have an increase in ICP, the PI, the pulsatility index will be more than 2, and this correlate well based on this evidence with ICP more than 20. So I normally use this number, easy for me to remember, 220, all right? Just to give an example, okay, I told you just now, you need to memorize what is the normal TCD look like, okay? In normal, you're going to see this is upstroke, and then you see deceleration kind of a waveform in diastole, right? You don't see here. In fact, what you see is actually there's a blunt, diastolic blunting in these TCD images, okay, PW images, right? So, how to use this? We can use this in triage tool, okay, as a triage tool. It's suspected, we can use it to suspect the possibility of high ICP, right? And some people use combination of PI index and the diastolic flow velocity to suggest a few conditions which almost similar to the increase in ICP, right? You can use it in monitoring of vasospasm following this subarachnoid hemorrhage. of patient that presented with a subrenal hemorrhage, eventually we develop a delay in ischemic cerebral ischemia, and increase in mean cerebral blood flow of more than 50 centimeters per second within 24 hours is predictive of this vasospasm. And this can be detected using TCD, right? And some people using it as a daily TCD monitoring in patient with subrenal hemorrhage. This is just an example. I told you just now, this is almost similar to the normal, we call it the normal TCD waveform. But if you really measure the mean MCA velocity, is actually 123. In keeping, this is actually in keeping of the probably a mild vasospasm, right? And there's a thing called Lindegaard ratio. I will explain this ratio after this, why we need this type of ratio. Right? When we use TCD to grade the vasospasm, okay, it makes sense that you need to differentiate whether it's mild, moderate, severe. So anything more than 80, I consider is a high. Okay, when you say it's a severe, when it's more than 200. Right, how sensitive it is very specific, almost 95% in terms of specificity, but it's less in terms of sensitivity. And so it's quite good as a triage tool and as a diagnostic method to actually rule out the spasm in a patient with subrenal hemorrhage. Okay, I mentioned earlier the Lindegaard ratio. Okay, why we need this kind of ratio? Because sometimes we're not sure whether this is a vasospasm or hyperemia, right? And we have to use this Lindegaard ratio, okay? LR. Normally, I just use this abbreviation of the LR. So in LR ratio, apart from getting your MCA, you need your ICA, right? So if you look back, severe more than 200 is a vasospasm, but we can use this Lindegaard ratio to actually differentiate whether it is a real vasospasm or just a hyperemia. Okay, in hyperemia, the velocity, the pressure in the internal carotid artery and MCA will be the same. So if you ratio it, put the ratio, definitely is meaning there is a the compared to the ratio will be more than 3 or more than 6, right? Definitely this is abnormal, right? So this is normal. This is definitely abnormal, but because you can't see the dust slick wave there, this totally abnormal because you see this is what we call the dust slick wave goes the other side, the negative side of the baseline. Right? So this is what we call a diastolic flow reversal, right? And in early phase, sometimes you see this diastolic blunting or some form of oscillating kind of flow or biphasic or oscillating kind of flow, right? This is a patient with several circulatory arrest due to subrenal hemorrhage. So how accurate is the TCD for brain death? This is a systematic review and meta-analysis published by Chum in American Journal of Neuroradiology in 2016. Interestingly, they found the TCD is highly accurate, okay, test for brain death confirmation, right? However, I need to emphasize this fact. TCD evaluate the cerebral circulatory arrest rather than the brainstem function. So what you get from TCD is just the circulatory arrest, but it didn't actually help us to give information how good is the brainstem function or how bad. So TCD is a rule-in several circulatory arrests by non-assuring this MCA flow, but shouldn't be used as standalone tool to confirm a brain death. Right? So the other application, I think most people interested now, I see a lot of evidence now using the CD, especially in this acute ischemic stroke. We're going to have a big conference on this soon, I was told. Right? Is number one, we can detect a large vessel occlusion, right? And by detecting the stenosis, by measuring the velocity, I mentioned earlier, normal will be around 80. If you see higher intervelocity, there is a possibility there is a stenosis of the MCA, right? But before come up with that conclusion, you need to exclude this. We have a few cases, in fact, probably over 10 years, we have 2 or 3 cases that presented to have us with acute ischemic stroke. But the true fact is patient is having aortic aneurysm, dissecting aneurysm into the carotid and throwing thrombus into the brain and causing acute ischemic stroke, right? So you need to put input. So sometimes we call it stroke mimicking, but the true fact is the main primary problem is the aortic dissection. Right? The second thing that we can use this in acute ischemic stroke is the quantification of this residual flow. I think most of us know this TB scoring. Okay, thrombolysis in the brain is using the TB grading, right? Just to show to you, this is TB5. This is the normal TCD look like. Okay, once you get started, I mentioned earlier, you get the increase. Sorry, and why this so? Okay. Once they increase stenosis, there will be increase in velocity. So you see there's increase in systolic upstroke, right? And it become dampened, okay, blunted, minimal, and absence, right? So the other thing that we can use in acute ischemic stroke is to detect possible intracranial hemorrhage. I think if you ask me, this kind of, if you have a CT scan, patient is stable, hemodynamic stable, I think CT scan is a way better than this. Okay, but if you live in an area, remote area whereby you don't have a CT scan, okay, patient is hemodynamic unstable, you cannot move patient to radiological suite for CT scan or MRI. Okay, this is another what I call it possibility alternative. And of course, similar to the one that I mentioned earlier, using the temporal bone, you might see all this. Just example, this is intracranial hemorrhage that we can see. This is similar. This is a presentation. This is images are CT images. This is the ultrasound images. Right. Right. Some people use it to personalize medicine, especially in individualize this targeted blood pressure. They use this peak systolic velocity. If more than 125% at the contralateral side, they lower the SBP to less than 140, right? For example, if the peak systolic pressure, the one that remember I told just now, the systolic upstroke, that is a peak systolic velocity, less than 125%, or MAP is less than 85%, they just maintain a current BP. I see some people doing this, right? And using this TCD to actually decide on this method. Some people use it in terms of prognostication for acute ischemic stroke. It indicates the successful of a reperfusion if they increase in TB flow over 30 minutes, and increase what they look at the TCD waveform is increase in end-diastolic velocity. Okay, and they can use it for post to indicate the possibility of post thrombolysis reocclusion if the flow decreased by more than 1 TB grading within 2 hours of the thrombolysis. Right. Right. In any diagnostic imaging, there is an advantage that is sensitivity is 80% sensitive is compared to angiography. But it's not every day we can get this angiography, right? Of course, in any ultrasound, it's always operator dependent, right? But I can assure you, if you have learned properly, okay, within probably 1 hour, 2 hours, you can get the concept of why we choose this, why we do this, how to interrogate the MCA. I'm very sure I can convince you. You definitely you're able to do it by yourself, right? Poor for distal vessels, except for MCA and ICA. That's why we choose MCA. Okay. There's a potential for fundus, for example, in hypocapnia. Careful with the hematocrit, hyperemia, if you want to look at the diagnosis of vasospasm, right? Hypotension and hypoxia, right? Edema and vasospasm were difficult to distinguish post-operatively. And of course, there's some view in some patients that have a thick skull. No wonder people say if you are kind of recalcitrant, the gale in Malay, okay, you have the gale otak tebal, thick skull. So this type of patient, in probably around 3 to 5% of patients you can do because they have just a thick skull, not just thick face, a thick skull, right? So take-home message is useful. If you ask me, very useful, especially when we talk about non-invasive neuro monitoring tool. It's a bedside, right? You can't ask for CT scan every 2 hours. Okay, use TCD can assist in the diagnosis, especially in remote setting. Okay, whereby you don't have sophisticated radiological imaging, for example, CT scan, MRI. Okay, but bear in mind, it's not going to be, it's not a substitute for this invasive ICP monitoring. Okay, it can serve as just to identify who actually patient at risk of intracranial hypertension, and it's very important. Any monitoring using ultrasound, it should be done serial. Okay, I repeat, I emphasize this fact. It should be a serial assessment. Right? Then only it can help us to have a better monitoring of several hemodynamic changes. Right? I think with that, thank you very much.
All right, thank you very much, Dr. Adi, for the interesting talk. Okay, I hope we learned something. For those who haven't been exposed to TCD before, I think this is a very good lecture about the introduction of the use of TCD and their applications in emergency setting. Okay, I can see there are a few questions from the chat. Okay, I will read it for you. Okay, the first questions, Dr. Adi, is doing TCD need a special probe? How about the common probe? Can we use it? Is there any substitute in terms of probe that we need to use when we do TCD?
Oh, the question from Prof. Septian from Indonesia. Right. So it's actually used your echo probe. Easy to say. Okay, use the echo probe. Right, and most ultrasound that is TCD is not an option now. Become standard in most ultrasound, newer ultrasound that probably you buy for the last 5 years. They have either TCD or TCI mode. So what you need to do is use that echo probe, press on the TCD or TCI mode, and that is your TCD probe, right? Which probe can be used to substitute? I think that the echo probe is easy. Unless you don't have an echo probe, you can use abdominal probe because it's same in terms of frequency, but slightly difficult to get the images. Those tests where we don't have our echo probe. Yeah, we used to use the abdominal probe. It still can be used. But if you have, I think, Prof. Satyan, I think your ICU you have this echo probe. Use the echo probe. Yeah. And press on the TCD or TCI mode. Then you have, okay.
All right, thank you. Okay, the next questions. Okay, thank you, Dr. Adi, for the great insight and step on TCD. Is there any role for TCD in other types of brain emergencies such as cerebral edema, spatial-cranial lesions, or infections in the intracranial?
The answer is yes for all the 3 conditions. Right, as I mentioned earlier, you can see the midline shift, right? Provided you can see the contralateral temporal bone, right? You can see a SOL, a spatial condition, because you see there's a destruction of the normal sonor anatomy of the one that I mentioned earlier. And in brain infection, for example, abscess, we used it, okay, as a early imaging before CT or MRI. We still can see. Right, it depends on the pathology itself. Right, early phase probably difficult. Okay, Cerebral edema early phase a bit difficult, right? But you can measure in case there is a increased HCP, you can look at the velocity and you can actually measure the midline shift, right?
Right. Another questions from Nina. In measuring ICP or estimating the ICP, which one is better, ocular use of TCD or the transtemporal?
The question should be which one is easier.
All right. Okay.
I think ocular is easier. Okay. I
Okay.
use it in patient with a traumatic, severe traumatic head injury, just a triage tool, because it's easy to get ocular. You can almost 0% not to get the ocular, right? And if there is an increased ICP, you're going to see the swollen optic nerve. I don't have the percentage, but the sensitivity specificity based on evidence. We have one evidence published by USM group. It's almost 90 something percent, 97%. So unless you're blind, you're going to miss it, right? But otherwise you won't miss it ocular. Okay, TCD. Ocular, what you get is subjective. Swollen or not swollen, normal or not swollen. TCD, you get the numbers. Okay, you get the velocity, and based on that velocity, you can convert into the pressure. Normally it's 2 more than PI more than 2 equivalent to the ICP more than 20. That's how I use it. How I use it.
All right. Okay. Thank you. I think another question: can TCD be done using portable pocket ultrasound, for example, Clarius or Lumify?
Before I answer the question, I have nothing against this brand, and neither I am actually promoting or selling on this brand, right? So the answer is yes. Okay. We have this VScan. Okay. We have this Cosmos. We still can do the TCD, but as I mentioned earlier, okay, the frequency is very important. Must be less than 2.5, right? And you need, I think most of these portable ultrasound, they don't have this TCD and TCI mode. You need to actually tweak a bit in terms of setting to get a good images of this MCA, right? The answer is yes.
Okay. All right. Thank you, Dr. Adi. Is there any questions from the audience? If you don't want to write it, you can unmute yourself and ask a question directly.
Can I ask a question?
Okay, Ashraf.
Yeah, Assalamualaikum, Dr. Adi. Thank you for sharing. I'm Ashraf, one of neurologists from UKM. Can I ask if you may share? Seems to be from the lecture tadi you share the TCI also, right?
Yes.
So transcranial imaging. So what setup you're using? So using a combination of ultrasound machine and TCD spectral capable machine, or you are using just TCI with limited spectral duration monitoring?
I'm using the normal ultrasound.
Normal ultrasound.
Normal ultrasound. So what we do is actually for normal ultrasound, we're able to get a good B mode. And once you get the B mode of the skull, the contralateral skull, then we put on color Doppler. And then once you get the color Doppler, we get the MCA, then we put a spectral Doppler inside, sampling using the spectral Doppler. It's almost similar to combination of both.
Okay. Thank you. Yeah.
All right, one more question from the chat, Dr. Adi. Does overlying hair disturb the visualization?
No.
Okay, all right.
You don't have hair temporal, by the way. Okay, so you don't need to actually shave.
Probably because the picture is over the hair.
So right. You can put what call it gel there if they're very hairy. Okay? So you put a gel there. Most of the time, it shouldn't be any problem.
All right. Okay. Any more questions from the audience? Okay. All right. If there's no more questions, I would like to thank Dr. Adi for having to give us a talk, a very nice talk. I hope all of us can learn it face to face in order to increase our understanding and the use of TCD. Okay, thank you very much, Dr. Adi, for spending your morning time on Saturday for our webinar.
We're happy to have anybody that interested. We just have a course with our neurosurgeon recently. So anybody interested, you can contact me directly. Thank you.
Yes, we will.
Okay. Probably we can invite you later on, Dr. Adi. I think if we have more awareness about this, probably we can invite you if you don't mind. All right. Okay. Thank you again, Dr. Adi. Okay. We're going to move on to our.
Saya stop recording dulu sekejap .